Good afternoon, everybody. Welcome to KourageConnects. We're honored to have Dr. Frank Ward speak to us today about colon and lung cancer screening. He's been a tremendous supporter of Courage Health over the years, and he is currently serving as our medical director. Thank you for your ongoing commitment to our organization and for taking the time to speak with us today about such an important topic, Dr. Ward.
Thank you very much, Trevor. And it is an important topic. It's actually one that might save a lot of us who have been spared so far in regard to these two cancers. And the question is, it's a difficult, depending on how you're screened, it can be found to be personally difficult for people to deal with the issue, particularly of colon cancer, which is an area of screening that actually is almost the way constipation used to be on TV. Remember, there were the ads where no one ever said they were constipated. They just said they were irregular. Well, I remembered Benjamin Franklin's comment in a letter that he wrote on February 4th, 1735, to the Pennsylvania Gazette. It was actually about fire safety. And obviously, he's a man of great genius. And he said the important point being an ounce of prevention is worth a pound of cure. And since then, that has been used in so many scenarios because it does help us prevent problems down the road. So I want to talk about screening colon and lung cancer. Obviously, for most of our audience today, cancer is a very personal thing and aware of what cancer is about. But in terms of the science that's behind the misery that many of us have experienced, the cancer is a genetic change in a cell, in an organ, where the normal growth regulation has been disrupted. The cells grow at an increased rate. They have the capacity to invade natural barriers. They have the ability to spread locally beyond their usual confines, regionally into distant sites, by way of the lymph system, by way of the blood system, and even by bathing in cell liquids such as occurs in the peritoneum. And they may also impact the rest of the body through the release of hormones and other products of the malignant process. The change is genetic, actually. Unfortunately, there are our own cells who have gone awry. They are no longer our friends. And it's a mutational change where the genetic code has been altered, leading to these various abnormal features, typically in steps over a period of time. And additionally, they have so-called epigenetic impact that can cause and contribute to cancer. Those are chemicals or proteins that change the expression of what may be otherwise a normal gene. And these effects seem to come from the impact of toxins, innate mutations. When a cell divides, there's always a possibility of its genetic code being misread or misinterpreted. Infection can cause these sorts of changes, as well as chronic inflammation and chronic stimulation. What about screening? What is screening about? Well, first of all, screening occurs when we're looking for a problem, whatever it may be, before there are symptoms, which is what the patient experiences, or signs, which is what other people, particularly a healthcare provider, can see. For example, if someone has a skin lesion, the symptom would be perhaps itching, and the sign would be a visible rash. We have from multiple experiences, including your own, that we're aware that early detection is possible with the current tools we have in our armamentarium. And with early detection, there is improved curability, reduced morbidity or adverse consequences to us, and lower mortality, the less chance of us dying from a particular malignancy. Screening allows more effective and less difficult treatment options in earlier disease. It can potentially improve quality of life as opposed to waiting for symptoms to occur, which also will have a greater impact in terms of often the level of treatment that's needed. And particularly, lives have been saved and well documented that screening has saved lives, both for colon cancer, lung cancer, and several other cancers. The issue is, as a society, whether the society is willing to pay for that screening process and the subsequent treatments that people may have to undergo if they're discovering their disease early in its course. Cancer, unfortunately, is the number 2 cause of death in the United States, with heart disease still leading the way. And both diseases have the potential to be affected by our lifestyle as well as our treatment options. The cancers that are currently most suitable for screening include colon and lung, as well as breast and cervical. Prostate cancer is controversial in terms of PSA, although I've had 2 relatives who prostate cancer was discovered early and successfully treated because of PSA monitoring in members of our family. So who do we screen? It's important to know how a disease evolves in order to figure out whether screening might be useful, either as eliminating a pre-malignant condition or as discovering the disease when it's relatively early. And with information about the evolution of the disease and who gets diagnosed and when, we can come up with at least 2 basic reasons for screening, because disease affects patients differently by their age and obviously by their gender. But there are other risk factors which we'll address a little bit later. Well, for age is a major risk factor that we look at for screening patients for colon or rectal cancer. And age, in the absence of other risk factors, is considered average risk. And colon cancer is a form of cancer that can be screened for average risk individuals or high risk individuals. And you can see from this bar graph that the great preponderance of patients, as in many cancers, increase as they get, the risk increases as they get older, particularly in the 64 to 75-year-old range. So that helps us decide who to screen, particularly for early cancers, because this is a high-risk group. And the question is, can we impact on their chance of survival by screening them? Well, how might we do screening? You can't see the top, but it talks about screening modalities for average risk patients, that is age alone being their risk factor, and it's focused on the bowel. And I bring this up first because this list of modalities is what discourages a lot of people from going through screening. And obviously, there's issues of expense, although Medicare, for those of us who are older, covers screening for colon, lung, breast, and other cancers. The gold standard, of course, is colonoscopy, which for the average risk person is recommended every 10 years. People are discouraged by the prep for it, kind of mess up your work day if you happen to be working while you're undergoing these screening. There is anesthesia, which means generally there's anesthesia, although I've known doctors who stayed awake during it because they had to do their clinic. But and also in terms of anesthesia, you need someone to bring you. And all these inconveniences beyond the cost, and those who either don't have insurance, don't have Medicare, are real obstacles for people wanting to get screened this way. Additionally, the invasiveness of colonoscopy and many of our inhibitions about how our body is treated can impact on people. The next one that is every 5 years for no major risk factors is CT colonography. That's been around for a few years now, and in the hands of some experts, it's considered equivalent to the previous optical colonoscopy, but it does require special training of the radiologist, and therefore it is going to be observational issues. You may, from your previous experience, know that radiographs, x-rays, CT scans can be complicated in terms of their interpretation. In CT colonography, There's a limited bowel prep. You drink oral contrast, and then air by way of the rectum is pumped into the bowel, and it's like a balloon that's been lined by the contrast. And you look for polyps and abnormal tissue. Obviously, there's risk for false positive and false negatives. False positive, what it's kind of like Scrooge. Uh, with it may be just a bit of potato, but it may be just a bit of stool that looks abnormal and then has to be followed by a colonoscopy. But it is an option for people who have average risk. Flexible sigmoidoscopy was something that was around, it has been around for a long time. It actually came out when I was in my residency in the 80s, late 70s. And it's a relatively easy technique. And but the problem is it only looks at the distal, the far end part of the bowel. It has a limit. It doesn't get to the transverse colon very easily, or to the descending colon, which is the early part of the large bowel. But cancers are moving away from that area toward the distal part. So it is an option. It's less invasive and requires just a local prep like an enema. And then there's a more complicated, having a flex sigmoidoscopy every 10 years, and then using a fecal immunochemical test to look for small, minute amounts of blood in the stool, which shouldn't be there if a person is not having bleeding from some site in the GI tract. And what you can't see on this, let me just take this down for a minute. You can see that colonoscopy has, in terms of 1,000-person years, like 1,000 people live 1 year, or one person lives 1,000 years. With that frequency of scoping, 28 lives are saved. And it goes down with the numbers as you see, with the flexible sigmoidoscopy alone being the lowest number. And in terms of much less invasive screening, we have the old stool cards. Those of you who are close to my age remember those, taking those home, and they had dietary restrictions, and you need to avoid red meat, and then you had to get the stool onto the card, which some people find objectionable. But the testing recommendations for average risk people is to do that every year, looking at a FIT, or a fecal immunochemical test, which uses antibodies to identify minute amounts of blood in the stool, obviously stuff that you can't see. And then using the same test with DNA, looking for essentially cell-free DNA from cancer cells that can be found in the stool with immunological studies. And again, you see that the old-fashioned guaiac test can save, if it's done every year, 24 lives. The immunochemical test, 26 lives. And then the DNA test, whether done every year or every 3 years, can provide protection for many people, really, overall, in terms of reducing the mortality than if they didn't have those tests. Now, there are a number of, as we'll talk about, there are a number of screening regimens, and it's not clear which one is best. One of the main reasons it's not clear is that people aren't willing to repeat certain tests, and the costs can be prohibitive if they don't have insurance coverage. There's very little straight up head-to-head comparisons among the tests. The organization, the initials are a little off there, the USP STF, little dyslexia, United States Preventive Services Task Force, has looked at many different things about our health to make recommendations about what we should be doing to stay as healthy as possible. One of the main points, and if you've done any of these tests, that's you'll surely appreciate, is that the test strategy that's used is really only useful if done on schedule. So one needs to consider and discuss with the patient what is the patient's likely to adhere to or likely to complete over their lifetime or over the number of years that they're expected to be followed. And it seems like getting a stool sample would be relatively easy, but I think we all know from personal experience, many of us always have something that gets in the way. And the next thing you know, a year is 2 years and 3 years, and then you may even get too embarrassed to come back. So, but you need to be adherent to the strategy, whichever you feel is best, either because of your personal preferences or cost or circumstances. It is unequivocal, however, that colon cancer screening reduces mortality. Now, despite that, more than 1 in 3 Americans eligible for colon cancer screening are not up to date on their screening. And it's important to be persistent and to stay on schedule, just like it's important to take your blood pressure medicines or your diabetes medicines or anything else in terms of trying to maximize your health. Now, what about screening that makes it useful for colon cancer? Well, first of all, as I alluded to, I believe that colon cancer goes through a sequential development. It begins typically with a polyp, which is an outgrowth into the bowel. And polyps grow relatively slowly over many years. And there are certain polyps that are totally benign, so-called hyperplastic polyps, where they're large, but it's just growth of normal tissue. And there are other kinds that are potential malignant progression. I happen to need, I have happened to have had numerous colonoscopies over many years because I have a history of adenomatous polyps, which over 7 to 10 years can develop into a cancer. So you have a long lead time to see if these polyps are present, and you can reduce or eliminate the risk of cancer by removing them during a colonoscopy. Obviously, you can't do that in any of these non-invasive fecal stool studies, and one has concerns about what polyps one may be missing before they become more advanced and worrisome and can progress to cancer. So you can remove the premalignant lesions, the benign, clinically benign but premalignant adenomatous polyps, and you can detect earlier cancers when they're more curable and treatable with a better prognosis and in the face of a growth rate that's relatively slow in terms of the development of the malignancy. Now, risk factors may increase with the number of polyps, the growth rate of these polyps, the cancer growth rate or progression. And these are things that are hard to predict for any individual, but in terms of population, the risk factors, some of which I will mention, help us make decisions about frequency and utility of screening. I've already mentioned that in terms of risk factors, age is actually the strongest risk factor in the general population. And that's how we decide when to screen adults here in America and other places in the world that have the opportunity to undergo screening. And age, because of the progression of disease from benign polyp, although it may be premalignant, of which there's the adenomatous polyp, the villus adenoma, the serrated polyp, sessile polyp, and the size has implications as well. But these can be removed during colonoscopy and therefore afford an opportunity to prevent the disease from taking place in the first place. And that's one of the amazing things about colonoscopy that I think made it clear to me, for me as an individual, what would be most useful is, besides screening for early malignancy, colonoscopy can actually prevent the development of colon cancer by removal of premalignant polyps. Family history is very important. First-degree relative with a history of colorectal cancer, that's colon or rectal cancer, or polyps that are considered advanced because of their size or the abnormalities of the cells that comprise the polyp, can be associated with a 2 to 3-fold increased risk for the development of cancer. So if you have a family history, if you have inflammatory bowel disease, those diseases are ulcerative colitis and Crohn's. And I think many of us are more aware of that simply because we hear and see commercials about these diseases, and they have increased risk of malignancy since they have inflammation and easier development of polyps in their bowels. Lifestyle may prompt consideration of colonoscopy over stool sampling, but still it's a consideration, it's not mandatory. But lifestyle includes many things that many of us suffer from, that is obesity, smoking, high diet of red meat or processed meat, and of course, we like our steak here in Texas. Diabetes, it's recommended that patients start their screening at the usual age, which is 45 for average risk. But diabetics do have a higher incidence and a worse outcome with colon cancer. So then colonoscopy, again, may be preferred since you may be able to remove premalignant lesions. And diabetes and weight issues are prominent among all of us as Americans, although smoking is going down other than in a very young age group where vaping is taking its toll. There are racial and ethnicity issues. There are populations that have a higher risk of colon and rectal cancer. And I've read actually two things, one or three, I should say. One was the highest incidence was in Alaskan Native indigenous people, and the other in Native Americans on the mainland, and others and other group mentioned has been African American. The thing about using colonoscopy with higher risk people is because some of these risk factors predispose to more fast growing lesions, which may be missed on stool tests that primarily look, if they have the DNA component investigated, look at the presence of mutations or cell-free material that is cancer linked in the stool, or looking at blood. Things are changing, however, and I'm the oldest of seven, so my anxiety is honestly a little higher about my younger brothers and sisters. Generally speaking, cancer in adults goes up in incidence as we get older. That's because over time we accumulate changes in our DNA, mutations, changes in how it's structured, that's so-called epigenetic changes, how it's expressed, turned on and off. We get older and our immune systems are decreased, which is why they recommend different types of or different forms of vaccines for older individuals. And lifestyle factors have accumulated. Some of us have smoked when we were younger. Some of us have had weight issues when we were younger. We've tried to beat them, but they may still impact on our risk. But now there's a whole new group of people that it's very worrisome about, particularly because of our current standards and guidelines for screening. For colorectal cancer, the early onset of those that are developing cancer at less than age 50 is the fastest growing demographic for colorectal cancer in this country. And it's present across all racial and ethnic groups. It's gone up, the rate has gone up over 50% over the last few decades, and typically is diagnosed in more advanced stages. I unfortunately had the experience of taking care of a 19-year-old young man here in Tyler, who subsequently died from colorectal cancer, who had bright red blood per rectum for a long time that was attributed to hemorrhoids. And these sorts of things in younger people need to be evaluated. I think that's the fairest thing to say. Bowel changes that are persistent, or bright red blood per rectum. These need to be evaluated because our bias is, oh, it's just a hemorrhoid. He's too young or she's too young to have cancer. Unfortunately, so many younger women with breast cancer have been told the same thing. But these sort of biases toward expecting that young people cannot get cancer, and the reason why, being unknown, why these young people are developing such a growing incidence of colorectal cancer, has ended up with 3 out of 4 of those who are diagnosed with colorectal cancer at less than 50 years of age have advanced disease. So either nodal involvement or even spread to distant organs. And part of that is because of our bias, our naivete as healthcare providers and as individuals, because we often say the same things when something happens to us as human beings. Oh, that's just my hemorrhoid. So be aware of that, please, particularly if you have younger people in your family or you yourself are less than 50 years old. And if you have these other risk factors, those that I'll talk about, the risk would be even higher. Now you've seen on TV the Shield, the blood draw, and this is the only FDA-approved first-line screening blood test. You know, the guy stand in the toilet emptying the toilet roll, and everyone's waiting outside for him, but he could have just gotten his blood drawn. It's based on cell-free DNA testing. This is DNA from cancer cells being released into the blood. And unfortunately, from my understanding, I mean, the earlier stage disease may not be as effectively monitored. Likewise, early polyps as those with advanced polyps or advanced stage disease. But again, if someone, this is approved, and if someone is unwilling to do other testing, this is a good one to go with because it is anticipated that it's going to make a difference over the long term. So in summary, let's look at screening. It reduces mortality. It's been shown that average risk begins at age 45 in terms of screening individuals. And then people should begin screening at age 45 if their age is the only issue. High-risk individuals start earlier and are often screened more frequently. And if they're higher risk, they may additionally have colonoscopies at more frequency, anywhere from 1 to 5 years, depending on the risk. There are multiple strategies, and it's important to follow the acceptable regimen that will allow the physician to be reasonably assured, a healthcare provider to be reasonably assured, and the patient to be reasonably assured that they can continue to be followed on a yearly basis. Obviously, if someone does have blood in their stool on their yearly or every other year, or every 3-year stool test, they will need to have a colonoscopy most commonly to see what's going on. We will talk about risk factors a little more that affects the strategy. And unfortunately, there's an increasing incidence in younger people, and bright red blood per rectum or significant bowel habit changes are red flags and not normal necessarily, for sure. Bright red blood per rectum is not normal. Now, the other, before we go on to lung cancer, the other issues that may come up in a misplaced slide in terms of risk factors include family history, genetic risk factors. There are genetic diseases where people have multiple adenomatous polyps, so-called Lynch syndrome, which is important if you've been aware of it, if you're aware of it, that these things need to be followed more closely. And other high-risk issues like multiple adenomatous polyps. These may require more frequent observation. When I was found to have an adenomatous polyps, I had to repeat my colonoscopy in a year over several iterations until they didn't find any. Then I graduated to 3 years and 5 years. So It's funny what makes you happy, right? Um, in terms of lung cancer now, this is no secret. The main risk factor and the most common cause for lung cancer is cigarette smoking. And it is going down in general, except among younger people. People have the impression that vaping is somehow safer. I could tell you in lobbying that I've done to try to increase the age for selling cigarettes or vaping devices to minors. There's a reluctance to give up smoking. It's useful to remember that the Marlboro Man, who was a symbol of manhood, uh, from my recollection, died of COPD, chronic obstructive lung disease. In terms of lung cancer, there are two main types, and they are small cell, and they're called those things because of what they physically look like under the microscope, and non-small cell, which has various subgroups. And they may differ in how they look on an X-ray or the extent of diagnosis, with small cell typically being considered a systemic disease, even when it's first diagnosed, and the role of surgery, chemo, radiation, or immunotherapy, which has had an increasing role and benefit in terms of helping people with these diseases. And the metastatic sites include the local nodes in the center of the chest or along the airways, the regional nodes there, as well as liver, bone, adrenal, and brain being common sites. And sometimes in this disease, because it is very, very sneaky, in this disease, it's the metastatic site that leads to the diagnosis and not the primary in the lung. And many of you may have been aware of that circumstance in some people. Other risk factors include secondhand smoke, which fortunately, as smoking decreases, it's going to be less likely to impact on people. Radon, actually, I don't know if this is required here in Texas yet, but when we first came here, you didn't have to have a radon inspection. And I don't think it's required still. But up in the Northeast, where I was originally from, you couldn't sell a house without a radon inspection. And workplace carcinogens like asbestos, which is also a risk factor for a very difficult disease, mesothelioma. Prior chest irradiation, which is a risk factor for breast cancer as well, and has been identified as a problem for young people that have had certain forms of lymphoma in terms of their need to be monitored later, and family history impacts as well. The other challenge that I alluded to is the symptoms in lung cancer always almost often occur, quite late. That is hemoptysis, that's coughing up of blood, persistent cough, weight loss, shortness of breath, chest pain, obviously problems that can have multiple etiologies. But the important thing is it should not be ignored, but unfortunately is more associated with more advanced disease. And here again, the potential utility of screening for lung cancer is in a person who is asymptomatic, which is the definition of screening. The potential utility is emphasized by the difficulty of treating more advanced disease. Now, lung cancer is less frequent, as you'll see, than colon cancer, but is more common than colon, breast, and prostate combined. This is an estimate for 2026 cases. I don't know if AI generated this estimate. I don't think so. Probably was the federal government. But anyway, 2026, it's anticipated that this year there'll be 158, close to 159,000 cases of colorectal cancer, with 55,000 deaths and a total cancer death number of 626,000. So colorectal cancer is no little deal. It accounts for about 9% of all cancer deaths. And lung cancer, you can see the significantly higher number, 229,000 cases with 125,000 deaths. It's more than half. And again, this includes everybody with early disease and late disease, and comprises 1 in 5 cancer deaths, 20%. So colorectal cancer is the third most common cancer. The second most common cause of cancer death, and lung cancer is the number one cause of cancer death, even though it has it partially reflective of the fact that it's often diagnosed late. Now, there was a lot of studies early on uh, looking at if using chest x-rays, which is a lot easier than what's currently being used and so commonly available for lung cancer screening, but it just doesn't work. Most studies have come to the conclusion that the data do not justify chest x-ray every year if you're planning to screen for lung cancer. Studies do show, however, that screening with low-dose CT scan does identify lesions with characteristics that can afford observation or biopsy, observation over time, biopsy if very suspicious or if it grows, or even depending on if it's very, very, very small, just essentially dismissing it. But it has been found that in screening for lung cancer, 20 to 24% reduction in lung cancer death rates have been identified. And to do that, you have to screen 265 people with 3 to 5 screens performed and 10 years of follow-up. Obviously, that's the deduction from studies that have been done. Now, what about guidelines for lung cancer screening? The major groups are the United States Preventive Services Task Force and the American Cancer Society in terms of the recommendations that I have come across. So I actually will admit that I was a smoker when I was young. I was in the military for 20 plus years. And they used to give those things away in your food packets when you're out in the field. So now smoking is actively discouraged in the military because of the health consequences. But anyone who's had a heavy cigarette use of greater than or equal to 20 pack years is a potential candidate for low dose CT annual screening. And the pack year, as you may know, I probably do know, is how many packs a day you smoked over how many years. Some people smoke an amazing number of packs a day. If you're age 50 to 80, and if you have smoked within the past 15 years, then you're eligible for an annual CT scan for screening for lesions that may reflect early cancers. The American Cancer Society says, never mind how long you stop smoking, you should continue to be screened. Lung cancer, unfortunately, is a very poor prognosis disease, and cure is most likely when detected at an early or very early stage. And as I alluded to, for small cell lung cancer, chemo is most commonly used, chemo plus or minus immunotherapy as the science advances, because the disease is considered systemic spread, even though it may not be detectable at diagnosis in most people. So if one has a 20-year or heavier smoking history, is 50 to 80 years old, or even a former smoker, the role of low-dose chest CT screening for lung cancer, I recommend, and the experts have recommended, should be discussed with your healthcare provider. And this is another example where an ounce of prevention is actually worth many pounds of cure, because lung cancer is a tough ride. So do not smoke. Or quit if you do. I actually quit because my future wife wouldn't date me if I smoked. Avoid secondhand smoke. Test your home for radon and reduce workplace exposures like asbestos, chromium, nickel, and other things that sometimes we don't even find out we've been exposed to until many years down the road. In terms of the costs, you'd have to see if your individual insurance policy covers it, but Medicare covers lung cancer screening with an appropriate smoking history, and colorectal screening for average and high-risk patients at their Medicare screening intervals. So is screening for colon and lung cancer worth it? Should each of us bother with it if we particularly if we have the resources? Uh, as Benjamin Franklin noted, an ounce of prevention is worth a pound of cure. So I would give an emphatic yes in answer to that question. Thank you for your attention. I think there are some questions in the chat.
Yes, thank you, Dr. Ward. That was really informative.
Thank you.
Really informative. So, yeah, we've got a few questions here. So, as I'm reading these out, if you want to get your questions in, feel free to type them into the chat. So the first question, is there genetic testing for lung or colon cancer similar to BRCA?
Well, there's genetic testing that involves the cancer itself. If one has certain markers in a cancer, it does give you information about the likelihood of it being a somatic mutation, that is part of that person's body. And there are also things like Lynch syndrome, familial adenomatous polyposis, and there are other diseases that have genetic markers that identify family members who may be at risk. They're not routinely just done. Similar with breast and other cancers for which there's genetic testing, one usually has a family frequency or a young member of the family. And typically, if you present with very young breast cancer, colon cancer, that the very young people often have a genetic basis. So, I mean, if someone gets any of these cancers out of the usual age group, that's a reason to consider genetic testing, because we don't know all the cancer-prone genes. I mean, it's an ongoing saga, and there are people now, they do multiple channel testing where they look at multiple different genes, and genes are being added as we have more opportunity to follow patients and investigate families and do the DNA, which is a lot easier to do now.
Great. Let's see, Deborah, what is the impact of secondhand smoke? Is it as impactful as one smoking?
Not to my knowledge. No, secondhand. First of all, fortunately, I mean, I think it's amazing that Tyler, Texas has no smoking prohibition inside public places. The Marlboro Man probably came from Texas for all I know. But anyway, but secondhand smoke is considered a risk factor, as is radon. It's probably not as easy to identify the nature of the risk, particularly because we really don't know how much secondhand smoke we're exposed to. You know, and then finding a population, you can't do a randomized study, you know, okay, you go into that smoky room and you don't go, and we'll see how you do. It's observation, and observation is very impacted upon by bias. I mean, if you're worried about secondhand smoke, you're more likely to remember you were exposed to secondhand smoke. If you're not worried about it, you may not even notice it. As I mentioned, I used to be a smoker. I didn't notice that I stank. But now I go by a smoker, it's kind of like, man, give me a break. We approach life differently. All for love, you know, who knows what I'd be doing now. Yes.
So what are some other colon cancer symptoms that young people should be aware of?
Well, the one that I think is the most deceptive is the bright red blood. You know, I mean, so many people have anal disease, hemorrhoids, and that sort of thing. And as I mentioned, that 19-year-old that I took care of had bright red blood for a long time, and they just said hemorrhoids, hemorrhoids, hemorrhoids. And you know, change in bowel habits that's persistent is not because you've gone on a new diet. Persistent abdominal pain, and these are general symptoms, just like if a young woman has persistent abdominal pain or abdominal distension, these are things that should be checked out. There's more than one reason that these things can occur. Um, unexplained weight loss. Of course, now everyone's losing weight because they're giving themselves injections in the arm, like on TV. But unexplained weight loss, it's very interesting. There is a neighbor of mine who was on a ketogenic diet, and I swore, I ended up calling him up because I thought he had cancer. He didn't. I know that now. And particularly, he told me it was his ketogenic diet. And this was many years ago. So, but anything that is not your body, if you have the resources, and sometimes if you don't, you have to get it checked out. And a lot of times the most dangerous thing is our own denial level. It's like, as a healthcare provider, I have to be pretty sick to go to a doctor. That's not reasonable. I'm not safer than anybody else. We fool ourselves. But those are the things that you're likely to be tricked by. Unexplained weight loss. I've been working out more. I cut back on my food, and bright red blood per rectum or persistent unexplained abdominal pain.
Great. What's one lifestyle change that we could make to lower our risk for colon cancer?
Well, we could go on a Mediterranean diet, but I can never remember what's in a Mediterranean diet. Now, if you send me to Italy, I can do it better, I'm sure. But diet is important for a number of reasons. We eat way too much red meat, and now that's a little bit easier to stay away from with inflation. I shop for our family, and it's unbelievable the steak costs. But our diet's very important, and exercise. And again, these aren't unique for colon cancer. Exercise, diet, avoidance of alcohol, smoking, those things affect colon cancer, breast cancer, lung cancer, kidney cancer. But it's not easy. I bought a quart of ice cream yesterday. I know I shouldn't have bought it, but I did. My wife and I enjoyed it last night. Lifestyle, and we all know what works, but it's quantity versus quality, and but the exercise, weight control, a more vegetarian based diet. We had a group of people visiting us from Europe several years ago. We lived in Texas, so my wife bought a Texas cookbook, all barbecue and all that stuff. And the person's mother said, "You better tell them that you're a vegetarian." So we got to give the book to somebody else.
I'll take it.
Say it.
I said, I'll take it.
Would a history of colon cancer in a second-degree relative necessitate earlier screening?
Not that I ever saw. No, it's a first-degree relative. The problem with some of these cancers, including colon, is people don't tell you they have a family history because no one told them. They keep it to themselves. It's, particularly if they had to have surgery and got an ostomy, it makes it more difficult for people to be upfront about the medical issues. And some people don't know. Obviously people who I've had patients who were adopted, they don't know what their family history was, or the family's estranged, or when you have to be willing to share with your family, which begins with actually being able to talk to family members. There are a lot of families that there's a lot of strife. So second degree, to my knowledge, no. At least not significantly. Let me put it that way. Gotcha. I already asked Wendy if people are going to fact check me. So.
All right, let's see. So from the use of my cancer treatment drug, I have daily diarrhea. What impact will a regular diarrhea issue have on the colon?
Irregular. Say that last part again, Trevor, please.
What impact will a regular daily diarrhea issue have on the colon?
I don't think it has any issue on colon cancer unless it's secondary to development of ulcerative colitis or Crohn's disease, which are significant intrinsic bowel disorders. Diarrhea from chemotherapy, I don't think has any relationship to colon malignancy. People who are struggling with one malignancy, particularly if they have a good prognosis, need to remember they should be screened for other malignancies as part of the regular screening or that sort of thing. So, I mean, treatment for malignancy and a diagnosis of malignancy is so overwhelming that everything gets focused on the moment, which is surely understandable. But when people start feeling better and their outlook is good, don't forget to continue to take care of these other potential issues, because unfortunately, too many people can have more than one cancer.
We have one last question here. Does vaping carry increased lung cancer risk, or is it too early to tell?
Say the first part again.
Does vaping does vaping carry increased lung cancer risk, or is it too early to tell?
I haven't seen any direct information about that, other than I was involved in lobbying to have vaping restricted for younger people. There's no reason to believe that vaping with its irritants is going to not have an increased risk. It may not be. There are so many carcinogens in cigarette smoke. We pick out the nicotine as the more prominent one, and it's. I mean, we're finding out about damages from marijuana smoke. I mean, malignancy issue with marijuana, I'm not sure either, but it's not good for you, in my view. It's not good for your lungs. And it's like, as I mentioned, I used to smoke. We need to listen to our bodies. Very few of us smokers did not force ourselves to smoke. I remember the first time you take a puff in and inhale, your body tells you this is horrible, but you keep doing it because your friends are doing it. You're sitting on the stoop. And so I have every reason to believe vaping is going to end up being shown perhaps not as significant as cigarette smoke, which is full of carcinogens, but it's hard to believe. And people are getting interstitial lung changes, damaged lungs from vaping. So I don't know those data, but our body tells us stuff. We just don't listen.
All right. Well, thank you so much, Dr. Ward. This has been really informative, as I said earlier. Thank you everyone for your questions in the chat. Yeah, so we'll have this posted up on our YouTube channel very soon. But yeah, thank you again, Dr. Ward.
Thank you. Really my privilege. Take care now.
Thank you.
Bye, everybody.
You're welcome.
Thank you.
You're welcome.